of introducing today's presentation and the speakers. Before we proceed, March is the Brain Injury Awareness Month. So I would like to take this opportunity to thank all the Beechwood Neuro Rehab staff, residential, clinical, nursing, and allied therapy teams for the exceptional work they do and for their commitment and dedication in treating our individuals with brain injury at the Beechwood Neuro Rehab. Kudos to all of you. I oversee clinical and psychiatry, so I have the opportunity to really work as a team. So today's presentation is actually about that approach, the power of collaboration, enhancing brain injury outcomes through person-centered and interdisciplinary approaches. So there is a lineup of wonderful people speaking today. The first one, I'll be introducing Tom DiNapoli, who has been with us at Beechwood Neuro Rehab almost 10 years. That's a long time. He's our senior cog therapist. He has a master's in clinical psychology from Chestnut Hill University and College. And he also has a certification in brain injury specialist trainer. He's a licensed professional counselor. And the next speaker is Cassidy. She's a licensed occupational therapy practitioner with 3 years of experience and passion for neurorehabilitation. She graduated from Jefferson University in 2022, and since then she has been at Beechwood Neuro Rehab. She also is a certified brain injury specialist and has further specialized knowledge and skills in providing individual care for individual participants with neurological conditions. The next speaker is Lauren McLaughlin. She's a speech and language pathologist. She graduated from Salus University with a Master of Science degree in speech and language pathology, and she has 3 years experience in speech and language pathology field and 13 years of experience in brain injury. She also holds the certificate of clinical competence in speech and language pathology. She's a certified brain injury specialist and is LSVT Loud certified. Lauren, you have to tell me at some point what that certification is. Next in line, we are so delighted to have Kristen Smith, who is actually a postdoctoral fellow with us from Immaculata. She holds a Doctor of Clinical Psychology, Psych D, Advanced Certificate in Psychological Assessments from Immaculata University. She's also a certified brain injury specialist. She obtained Master's of Arts in Counseling Psychology from Immaculata and Master of Education, M.Ed. from Widener. And prior to that, she was certified in special education, elementary and early childhood education. She is also an adjunct professor at Immaculata University. I'm just impressed with the number of presentations she has lined up. So good to have you, Kristen, with us. And without further ado, this is Tom. I think you are the first speaker, if I'm not mistaken. It's all yours.
Yes. Okay. Thank you so much. Good afternoon, everyone. And thank you, Dr. Musunari, for that wonderful introduction to our team at Beechwood. As you had mentioned, you can see that our presentation is going to be really focusing on what person-centered care is and how that applies to our individuals from a wellness perspective, and how having this interdisciplinary team really is so important to how our individuals are able to achieve their best abilities within the community and independence. So as you can see for our outline today, I will be introducing what the wellness wheel is, and briefly talking about our interdisciplinary team, strictly focusing on clinical today, as that's what we'll be presenting. And that's going to include cognitive rehabilitation, neuropsychology, with assessment and therapy, speech language pathology, physical therapy, occupational therapy, and then we will be having a brief case study at the end, to protect the anonymity and to follow HIPAA. We have changed the initials to this individual to BW for Beechwood, and we will be presenting on how our disciplines and person-centered approach has been able to help our this case study achieve the best of his abilities. So here you could see we have what's called the wellness wheel. I really want to highlight that this wheel is not just applicable to the individuals that we serve at Beechwood. This is applicable to every one of us in our everyday lives. So when you're looking at this wheel, you have the person in the center, and it's talking about the different types of wellness. And when you have all these in place, essentially you are overall in a better place mentally, emotionally, socially, spiritually, intellectually, physically, and financially. And these are all things that we will be highlighting throughout the presentation to show that how our disciplines, how each of our therapy different areas of the wellness. So as Dr. Musunari had introduced right at the start, our interdisciplinary team, it's quite large here at Beechwood, and as well as Woods. We have a pretty big collaborating team. So we have clinical, which is what we're going to be presenting on today from our clinical team in the different disciplines. We have our care coordinators who are responsible for keeping up with so many difficult tasks of, keeping up with funding and insurance and making sure that RSPs are being up to date and all of that. We have our nursing, residential, we have the medical center, and then we also have psychiatry as well. And all of these are what we do to work together to go into that wellness wheel that was on the previous slide. You can switch, Cassidy. Yep. Okay. So briefly, I'm going to try and make it quick. I just wanted to go over a little bit about basic brain anatomy. I think it's really important to highlight that one of the strengths of our team, specifically at Beechwood, is during the introductions, if anyone was listening, you would see CBIS, right? CBIS. We all have this CBIS. What that stands for is we are all certified brain injury specialists from the Brain Injury Association of USA. And we have 2 certified trainers here at Beechwood to get our staff certified. And I always like to highlight that. So myself and Dr. Joe DiCandina, our clinical director, are both certified trainers. And the reason we have our trainer certificates and we want to get our staff as educated as possible is because a part of the person-centered approach is we really want to be able to understand the individual and understand the complexities that go on with TBI. So I just want to briefly go over a basic anatomy of the brain of the 4 lobes. I'm not going to go into any specific detail with like any scientific terms. So just the 4 lobes. So we have the frontal lobe, which is the last part of the brain to develop. So the earlier the individual is injured, the more severe impairments you would see with like problem solving, some personality, what we like to call our executive functions. That's in our frontal lobe. Then we have our parietal lobe, which is our sensory input and output. We have occipital, which is our vision, and then our temporal lobe, which is long-term memory, as well as expressive and receptive language. So I'm not going to go too much into detail about what's in each lobe, but just how the lobes function and the way we are able to understand our individuals and their complex needs. So this person-centered approach, we hear this all the time, what person-centered, client-centered, however you want to call it. So this is the main type of, I guess, model or treatment theory that we provide extremely well at Beechwood. Person-centered care, it was developed from an American psychologist named Carl Rogers, and he had studied human behavior and had found out that the importance of interacting with others and what's important to an individual is really how it helps their well-being. Beechwood understands that person-centered care is extremely important, and we focus on really what the individual's needs are and what they think is important to them. So that's what we will be focusing on when we talk about the case study, how this person-centered model focuses on the needs of the individual as it relates to our interdisciplinary team. And then one thing that we do is that we use evidence-based practices. So, for example, we utilize so many different therapy techniques that have been clinically proven and studied to have outcome-driven improvements. So one of the examples that I always use, I just have my cognitive manual right here. This is the updated cognitive manual from the American Congress of Rehabilitation. They are constantly updating their research on how to improve memory, how to different techniques that are in this cognitive manual that I could speak to from cog rehab that I do from an evidence-based practice, and then our other clinicians have their own evidence-based practices that they do as well. Okay, and then briefly, I will talk about the cognitive rehabilitation therapy, which I provide here at Beechwood. A lot of people, a lot of individuals, I should say, that come to Beechwood when providing therapy, they don't fully understand what cognitive rehabilitation is or what cognitive therapy is. And I always tell people cog rehab is it's very layered because it overlaps in so many different areas of what we do here at Beechwood. Essentially, your cognition is how your thinking controls your behavior. So I have thinking as the first there. I have our problem solving, our organizing and planning, and then really importantly, awareness, teaching individuals to be aware of their own impairments and deficits, as we see that a lot of our people within brain injury, depending on the severity of their injury, can lack awareness of what their impairments are, and things like that. We can switch, Cass. And then this is just cognitive rehabilitation therapy continued. I added this slide because in order for cog rehab to be functional, neuroplasticity needs to occur. Neuroplasticity is just a fancy way for explaining that we can make new neuronal connections, so we can have more neurotransmission within our brain. So the neurons can travel through the axons and make synapses. And then the individual's ability to adapt to these changes. And I will get more, or our team will get more specific into that when we talk about the case study and how we use our different disciplines and how our people adapt into the community.
Okay.
And I believe that is my section. All right, you're up, Kristen.
Yeah. Thanks, Tom. Okay. So welcome,
You're welcome.
everyone. I just wanted to speak today about neuropsychology. So it really is a subspecialty of clinical psychology, but we really dive deeper into the brain behavior relationship. So we need to know a good amount about really medications, also the background of the biology of the person's overall functioning, and then again, basic psychology, and then the brain.
All right. So where do we start? We're going to start with assessment. So we'll do an additional assessment after we bring in the person to see if they're a good fit for Beechwood. We'll go and do a neurofunctional evaluation to just see their baseline. The goal here at Beechwood is to do best practice of every 2 years. We're really striving to evaluate every single individual here to see how they're progressing, to see if there's anything extra that we can add in for services. So that's the goal. Also, we have the Office of Vocational Rehabilitation evaluations. We're excited about those, and we have one coming up soon as well. So on an outpatient person would come in and we would do an in-depth study of that. So on top of assessment, we can narrow down types of individual therapy. So we have neuropsych therapy. It may look different in terms of the person's needs. Let's say that they have difficulty with a vision impairment or understanding language. We really have to adapt the way we do traditional therapy. So keeping it person-centered, but driving it towards their basic needs based on the assessment. We love groups at Beechwood, so we really encourage socialization. A variety of groups I'll get into in a little bit. And of course, crisis intervention is kind of ongoing. If we see something that comes up, we just are always keeping our eyes out on everything. So I also do cognitive rehabilitation, just along with Tom, who trained me pretty well. And then we're always collaborating with the whole team all the time throughout the day when we pass by each other, and it really makes us special. All right, so what does testing look like? We're really diving into specific areas of brain that are we're showing deficits in, or patterns of strengths or areas of growth, so we can understand how these impact the person's overall functioning at Beechwood. So again, we can establish a baseline to track that over time. So with the information that we get from our assessments in collaboration with the whole team, we're going to make SMART goals, so specific, measurable, achievable, relevant, and time-bound goals. So with those SMART goals, we can just really drive our treatment, personalize it based on their needs. So this is a typical example of what we would do. The person always has their schedule laminated right in front of them because they are busy every single day going from therapy to therapy. But we can also add in cell phone technology, assistive technology to make sure that we're treating their specific areas of need. And then hopefully we'd love to also have them have employment opportunities and volunteer opportunities. So thank you, Cassidy. When we're doing the assessments, we look at the biological background, so any kind of physiological issue that they may be coming in with, look at their strengths and weaknesses from the assessment, and then we like to observe how they're doing in their residences, in the clubhouse, in Inspire, so those are the day programs, and then we can incorporate how everything works together. Okay. So here's a sneak peek of some of the assessments that we'll do. So at the top, we have the DCAFS trails. So we would see cognitive flexibility and how well they can kind of shift this frontal lobe region of the brain that might be impacted by brain injury. The clock drawing is on the bottom, so we can see if they are having trouble conceptualizing a drawing of the clock with the numbers, or if there's something else going on, like a dementia-related process. So these using standardized measures. So these are all the areas that we like to assess. Some go into personality measures as well, but it's hard to tease that out between traumatic brain injury and what is an actual personality disorder. But a lot of times people also have challenges with theory of mind. So knowing how to read faces, being able to understand the social pragmatics. So we look at that as well. Okay. So additional screening measurements would be objective and projective measures. So We can check adaptive functioning, mood and anxiety, and we also always like to see how we can incorporate this into the RSPs to track progress. So something would be like the Beck Depression Inventory, the BDI. We can see based on the numbers if depression symptoms are decreasing, increasing, and then target those. Okay, so here's the nitty-gritty of the brain. I won't get into it today, but let's say somebody with testing has expressive or receptive language difficulties. So parts of the brain would be the Broca's area or Wernicke's area. We would see that on testing and know that, okay, they're having trouble interpreting language. That's definitely going to impact what our therapy sessions look like. So we're really going to need to think outside the box with more visual aids, with a lot more practice, and add in some extra groups and practice outside of therapy. Okay, so a common concern for people with brain injury would be anger, irritability, emotional dysregulation. So that would show up in their moods and feelings, how they're thinking about themselves and others, how they get along with others, and then just self-control. So those are specifics that might be impacted. So what would we do using person-centered and then evidence-based practice? We would probably target dialectical behavior therapy for emotion regulation. But let's say somebody has a lot of stressors, trauma. We could add in other therapies like mindfulness-based stress reduction to target those areas of extra stress, irritability. And looking at the science, current science right now is really hot on polyvagal theory. So looking into that to see how we can kind of reset the nervous system that can be impacted through brain injury. Okay, so common areas that we work on in individual neuropsych, specifically, like I said, for the person with irritability, we really target emotional regulation techniques, but they may also have substance use, they may have trauma. So those are things that we would look at as well. Okay, so groups, like I said, we love groups at Beechwood. What would the groups look like? Well, they would really help with the person reducing isolation, feeling alone, different with a brain injury. They would connect with others with similar experiences, and then have that supportive group with everybody there to kind of cheer them on and practice those social skills. Okay, so here's some common groups. The person, let's say, with irritability, we may have them in an open process group to kind of share and process their concerns. We might also have them in navigating relationships group, let's say, so that they can practice those skills in the relationship group. Based on how they're doing in their residence, some people in the houses also may not get along too well. So we can have them in a group based on their house that they're in and work through issues that might show up outside of our daytime programming. Okay, so last two slides, this is just a snippet of what a DBT program or skill set would look like. We'd practice mindfulness, again, distress tolerance, emotional regulation, and interpersonal skills. So again, going based on what the person needs as a whole, communicating with all of everybody at Beechwood, and then honing in on specific skills. And before we move on to speech and language, good visuals that we like to use a lot. This is from DBT and polyvagal. So Dear Man is one that I teach directly in terms of managing difficult conversations, describing how they're feeling, expressing themselves, being assertive, and then really reinforcing that outside of therapy and practicing it. So, all right. So I want to make sure we have time for everybody. Moving on to speech with Lauren.
Good afternoon, everyone. So I will be presenting on our speech language pathology and speech therapy services at Beechwood. So what is speech language pathology? So our profession is dedicated to prevent, assess, diagnose, and treat speech, language, social communication, cognitive communication, and swallowing disorders for individuals of all ages. Our scope of practice covers fluency, speech production, language, cognition, feeding and swallowing, voice and resonance, auditory, pragmatics, as well as communication modalities. So, common communication challenges that we see following brain injury include the following. We have aphasia, which is a language disorder that causes difficulty understanding language, reading and writing, and those literacy skills. We have apraxia, which is difficulty coordinating the movements required to produce speech. Dysarthria, a motor speech disorder that results with slurred, weak, or slow speech. Dysphagia, that is difficulty with swallowing, so foods or liquids. Dysphonia, a voice disorder that causes changes in voice quality. That can include hoarseness, raspy, or breathy sounds, as well as difficulty with pragmatics. So that's using language appropriately in social situations. So how does speech therapy address the wellness wheel for our individuals? Brain injury can affect an individual's word finding abilities, their speech rate and volume, their speech intelligibility, or how easily they're understood by others, as well as pragmatic skills, including turn taking, appropriate topic material for the communication partner they're speaking with, as well as topic maintenance and the gestural or nonverbal cues such as eye contact or facial expressions. So in therapy, we help restore those social communication skills by building confidence, by improving a participant's speech clarity, fluency, vocal quality, vocal volume, and pragmatics. We assist them adapting to social settings. So we will do role play of conversations and help model those appropriate pragmatic skills, as well as introducing AAC devices, communication boards, or other speech generating apps to help those individuals facilitate communication and conversations, and then overall help them reintegrate into their social circles and community. So develop the strategies to navigate difficult social situations, reconnect with friends and loved ones, participate in community events. And as well, we have multiple speech groups, which we'll discuss on the next slide, that help provide a structured setting for our participants to practice their communication skills in a supportive and interactive environment. So those Beechwood speech groups that we offer include our AAC group, which is augmentative and alternative communication, which are methods that are used to supplement or replace speech for individuals who are limited in their verbal skills or are nonverbal altogether. So in those groups, our participants utilize speech generating devices, most commonly iPads, with a speech generating software. In our pragmatics group, we focus on appropriate social skills. So the participants will practice turn-taking skills, topic maintenance, expressing their opinions, and the nonverbal cues that we discussed before, like eye contact and appropriate facial expressions. Our current events group will engage in reading and comprehending current event articles, and this is by summarizing and recalling information, as well as asking questions and providing their own opinions. Our speech technology group has our participants utilize their cell phones, tablets, or iPads, and we target increased social communication. So this includes texting or emailing with family and loved ones, modeling and utilizing apps for leisure. Common ones are Spotify to listen to music, and also the local library app to access free materials, podcasts, or books. And then we also have our expressive language and motor speech group. So this is for our individuals who have motor planning difficulties, including the apraxia or dysarthria disorders. And this provides a safe space for them to practice their compensatory strategies and express themselves with adequate support and the patience they may need. So speech therapy addresses individuals' emotional wellness by helping them express their feelings. Brain injured individuals have reduced feelings. We help them reduce feelings of frustration or depression and anxiety that they can have due to their communication difficulties. And we help this by implementing compensatory strategies as well as those alternative strategies using the devices, low tech or high tech. We help build confidence and reduce their anxiety by regaining communication skills in a supportive environment, reducing any fear of social interactions, and support their emotional regulation and help manage stress. Speech therapy is also providing advocacy and caregiver support. So we are promoting and help facilitating our individuals' access to AAC devices or any modifications they need for communication, as well as providing support and education and any emotional support for the participants, their family, and any caregivers. Speech therapy addresses physical wellness in a variety of settings. For example, swallowing therapy, we provide swallowing exercises, monitor oral hygiene, modified diets, and posture adjustments. This is to improve swallowing safety and efficiency, reduce any risk of aspirations or malnutrition, and overall just help maintain that quality of life. With breathing and voice therapy, we target respiratory training, breath support exercises, vocal hygiene, and vocal function exercises. So this is to increase respiratory strength, vocal strength and their volume, as well as sharpen articulation skills. Motor speech therapy consists of oral motor exercises, tactile cues, working on prosody or intonation, and this is to target and improve range of motion and control of the speech muscles, enhance our speech sound placement and sequencing, as well as increase overall speech clarity and intelligibility. Intellectual wellness. So we also deal with cognition and some of the cog rehab goals. We have overlap there, which is nice. We work on reading and writing skills, including functional reading exercises, strategies for summarization, and implement visual supports. This is to improve letter and word recognition, increase reading comprehension, and help repair the individual's phonological awareness. For cognitive communication, we work on memory, attention training, organizational strategies to overall improve attention and memory, increase a person's orientation skills, and overall effective communication. And executive functioning, working on self-monitoring, verbal reasoning tasks, and implementing any external aids that could be helpful to increase self-awareness, problem-solving skills, and organization of information.
All right, so I will be turning it over to an occupational and physical therapy standpoint and just talking a little bit about how our two professions are working together to support our individuals throughout their lifespan while they reside at Beechwood. So I would be remiss if I didn't take the opportunity to just separate and compare and contrast what occupational and physical therapy are for those of you who might see a little bit of the overlap and aid into that little bit of that confusion. So occupational therapy works on supporting success and independence in all occupations. We're looking at addressing skill development and providing compensatory strategies with the underlying goal of improving functionality within a person's life. Physical therapy is really working on supporting rehabilitation of physical strength and function to improve their quality of life, improve accessibility, and provide compensation techniques when necessary. So while they sound pretty similar, we are different in our ways of what we are looking at skill-wise and how we are tackling the interventions to best support our population. Where we do see some overlap is that we are utilizing evidence-based practice, as Tom touched on earlier this presentation. We are addressing physical and environmental barriers, as well as some social other barriers that would impact quality of life. And we are improving their overall independence while maintaining a low level of caregiver reliability. So for physical therapy interventions, you'll see here a list of their commonly used interventions within our brain injury population. These are generalizable to both our TBI and our anoxic brain injuries, which present very differently. So they're looking at gait training, range of motion, motor planning, or motor coordination as these skill development strategies to support the physical deficits that some of our participants present with. They are additionally providing home exercise programs, activity modifications, or wheelchair and adaptive device recommendations. So this is something that I'll touch base with in the next slide, but they are providing a wide range of interventions to best support each individual deficit area that our clients are presenting with, because they are pretty complex in their physical and cognitive presentation and require a multifaceted approach to best support their outcomes. So how physical therapy is supporting physical wellness in terms of the wellness wheel is that they are promoting optimal health by increasing quality of life and functional independence through those means that you see listed. So this is where wheelchair and DME recommendations really come into play for our physical therapists. Our team is really great about analyzing and assessing and connecting with appropriate vendors to get the equipment that our participants need to support their independence. As you see pictured here, this is a modified ankle foot orthoses, or a MOFO for short, which is something that our PTs often recommend and have casted and customized for our participants to support ankle and foot instability that would impact their walking. They are also often connecting with our vendors to do customized wheelchair assessments for each of our participants, as a lot of them are wheelchair bound and rely on customized seating, lightweight wheelchairs or something like that to make sure that they can remain as independent as possible while considering the medical components of bed sores and pressure ulcers and stuff like that. Physical therapists are also supporting emotional wellness. So this is maybe an area that people are not always thinking of PTs supporting, but is very prevalent within our population. So the emotional aspect that they are supporting is that by getting our participants up, getting them to engage in their physical therapy sessions, they're enforcing that release of endorphins, which is therefore reducing the stress and anxiety that a lot of our participants so often experience. It also assists in reducing pain, which is something that is quite prevalent in our traumatic brain injury population. They typically have a lot of pain with their hemiplegia. So that is an area that they can kind of support from an emotional aspect, just to decrease those mental health symptoms. They also address healthy eating. So a comorbidity that we often see with some of our participants here is diabetes. And this is an area that PT can intervene in and support by providing meal planning and nutrition suggestions, providing home exercise programs, which all comes together to promote wound healing and increase strengthening. So environmental wellness from a physical therapy aspect. A lot of our participants live with us on campus. We do also see a host of outpatient participants as well, which means that we are catering to a wide variety of environmental recommendations. So some of the things that they are looking at is making sure that they are providing our participants with increased access into the community and addressing their environment in the home. So you'll see some of the big areas that we're recommending for our residents or our participants that live here in the residences are grab bars. We're making sure that there's no tripping hazards within the room. Something else that's great that our physical therapists do is that they can order and provide custom footwear for our participants that decreases the risks of falls in the residents and out in the community as well. Physical therapists are also working on occupational wellness. So they are able to provide, this really applies to some of our outpatient as well as some of our clubhouse members that are engaging in structured day programming. They're part of a work unit, they have job responsibilities, or if they're an outpatient, you know, they might work part-time, or even some of our apartment people are employed through OVR or job coaching. So physical therapists can assess and determine what modifications these participants might need to be successful in the role that they are placed in order to fulfill that aspect of their quality of life. So I'm going to switch gears a little bit, and we're going to address the occupational therapy scope of practice within brain injury. So speaking from an OT terms, we are looking at supporting activities of daily living and instrumental activities of daily living. So as you see here, the big ones that are prevalent within our population are bathing, dressing, home management, money management, communication, functional mobility, the day-to-day things that are sometimes very difficult for somebody who is wheelchair bound or who has physical or cognitive impairments that limit their success. Other occupational areas that we are looking at can include community travel, work, and social integration. So this is just a more specific list of occupational therapy interventions and what we are looking at when we evaluate and assess our participants. So we are looking from things like executive functioning to vestibular to vision to home management to community travel, and really formulating a holistic picture of the deficits that this person presents with, so we can form a cohesive treatment plan that best suits their independence. How occupational therapy supports physical wellness is you'll see that we work on quite a list of skills within our sessions that directly correlate to the outcomes that you see on the right side of your screen. So we might be addressing balance or functional mobility with DME. We're often looking at bed transfers or toilet transfers. We're looking at upper extremity impairments, whether it's a subluxation from hemiplegia or carpal tunnel or just something that they're experiencing. We're providing either skill development or compensatory strategies to support their physical wellness and increase their safety within the residence, as this is always our overarching goal, in addition to supporting their own independence in their care. OT is also very heavily into the occupational and social wellness. So again, we're taking into consideration our participants' work or, you know, their day-to-day needs. A lot of our guys, this includes structured day programming, whether it's Inspire or Clubhouse. They might have volunteer opportunities within the local community that we are looking at to assess them and support them with whatever recommendations or skills that they need. Social wellness, we are looking at social groups or individual sessions. We also provide community travel assessments and clearances, and we're providing family training for home visits with family for our participants that have family locally that are interested in coming and supporting them and taking them out for a social integration themselves. We're providing some wheelchair training, or we're providing like how to best transfer them. And the overall outcome of these interventions is just an increase in quality of life and increased safety of our participants. Occupational therapy is also supporting these supplemental areas of financial, emotional, and spiritual wellness. This includes money management. Some of our participants who live in our apartment program are responsible for a heavy amount of their bill paying responsibilities. This could also look like spending money on community travel experiences and learning through those naturalistic experiences. We are supporting through emotional regulation. We have group and individual sessions to allow for structured and natural learning opportunities. And spiritual wellness, we do have the opportunity to provide supports for our individuals who want to seek out spiritual opportunities. We do also promote yoga groups throughout the week, which is a fan favorite amongst our participants in order to just kind of stay connected, and that pairs well with the emotional wellness as well. So we will move into our case study of BW. He is a 36-year-old male currently. He was initially admitted into Beechwood in 2017 at the age of 28. He is admitted into a level 2 housing assignment with one subsequent move since his admission. His injury was a TBI as a result of being hit by a van at the age of 12, where he remained hospitalized for 8 days following his initial injury. He was referred to us from a different facility where he resided for 7.5 years prior to his admission to Beechwood. So I will let everyone come together and just kind of explain their individual role in this case study. But from an occupational and physical therapy standpoint, we've supported this person throughout different stages of their life while at Beechwood, from their initial admission to now. So this is somebody who came to us who's independent in his ADLs and really wanted to focus more on IADL performance and those higher level occupations. So since his admission here, we've provided him with community travel training. This was something that he initially was not successful with when he first transferred to Beechwood. But over the years, as his skills have developed and as he's really received structured intervention from the transdisciplinary team, he's been able to work on these skills and be successful in community travel. So now he's able to enter and engage with the community around Langhorne really well, very independently, and he's very safe, which is what we're looking at when we're providing these community travel clearances. He is someone who's also been working on meal preparation within his residence just for some increased independence and to decrease, the reliance on caregivers to provide each and every meal for him. So this is something that was given to him about 3 years ago. That was a preferred goal for him in that time, and he was able to generalize some of the skills that he's learned throughout his clubhouse experience and some other therapies to really put forth the effort into this IADL area. And then recently he has undergone receiving a set of dentures. So this is another area where occupational therapy was able to support him in providing him with interventions to be successful with his denture care. So that is a little bit of the occupational therapy realm for this person. In terms of physical therapy, going back towards that community travel bit, he rides a bike to and from his residence and Beechwood, which is something that he had to be assessed and cleared for. And this was something that our physical therapy team was responsible for supporting him in while he was here. So I will turn it over to, let's have Lauren adjust his speech.
Okay, so for BW in speech therapy, some of the main goals that he has been working on with medication management to increase independency with ADLs and being able to take care and self-administer his medications, as well as literacy. So he has been working on his goal progression has gone from initially matching medication names to the rationales for the medicines, and then being able to identify independently medication names, rationale, and dosages, and working up to independence and knowing the medication names, how to write them out, the rationale for what those medicines are for, his dosages. So we're working on complete independence in that area.
Are you ready for me? Okay. Okay. For the neuropsychology standpoint, BW is working on social pragmatics, so understanding the nuances of nonverbal communication skills and turn taking in terms of when it's appropriate to speak, how to speak, and working on assertive communication. So this really overlaps a little bit with every other area. For individual therapy as well, we're working on overall coping skills, specifically for anxiety. We have, BW has challenges with skin picking, which can increase around specific times of year, holidays, or when anxiety is increased. So we're working on reduction specifically for anxiety and skin picking. So BW's in a number of groups within the house group, and navigating relationships, and has 2 hours of individual therapy as well. All right, Tom?
All right, cool. I see that we're definitely running a little short on time, so I'm going to be brief with my section, and then the next slide or two, just so we could, if anyone has any questions, I'll leave some time for that. As far as cog rehab, what I work on with this individual is his budgeting, problem solving skills, and awareness. The awareness I will get into a little bit, I believe, in the next slide when we talk about the goals that we have listed for this participant. So, Cassidy, do you mind if I take over from here?
Go right ahead.
Just to make sure I'm not overstepping. Okay. So for individual OT, we have meal planning, community travel, denture care, and then executive functioning group and men's health and relationship group.
This is just a
Medication
look at
management,
his-
reading comprehension. Yeah, for speech. Okay, yeah, so when we're talking about the examples of our individual goals, as far as goes, I really wanted to highlight skin picking, and I'm going to focus problem solving, particularly from a meal. This and previous diagnoses before his injury from other diagnoses. However, the anxiety with this individual is highly increased by the amount of caffeine and sugar intake. And we, as the entire team, just the amounts of the intake of sugar and caffeine, and being able to read the labels like on snacks and foods, and actually understand how much is 30 grams of sugar. How I have I'm Smith certified, so I can drive and get one of the vans. I will take the times, and we will read food labels together to go through the understanding that aspect. So these are just examples of our goals that we work on in our individual sessions. So for me, it's problem solving to improve his independence with ADLs, neuropsychology, looking at different coping skills to understand that anxiety, and the skin picking for speech, being able to understand the dosage of his medications, and for occupational therapy, the importance of dental hygiene, as well as using compensatory strategies such as his cell phone or an Alexa and what have you. All right.
First
So
of
do we have
all,
any-
thank you. Thank
Yeah.
you for the beautiful presentation. I'm just amazed at the work you are all doing over there. And the number of groups, I never realized. I look at the schedule, but it's really amazing, amazing. I have one quick question for Kristen. Dear man, is that more specific for a cognitive deficit, or can it be applied to the general kind of like population as well?
So originally it was designed for, that's part of DBT, designed by Marshall Linehan for borderline personality disorders. So it has been used in various populations, but I'm finding it's really helpful specifically with TBI, one, because there's visuals, there's acronyms that are pretty easy to pick up and memorize or learn, and they're easy to practice in groups, individuals. So it's really geared, that can be used in any of the practices that we're using, whether it's speech and cog and neuropsych, but that's kind of a background gist of it and a snapshot of one thing that I do.
Thank you.
Mhm.
I heard it before. I was just trying to figure that out, that, which one is the more specific one. We can take questions, maybe one or two from others. I'm trying to see if there is anything in the chat. You can unmute yourselves. Looks like no one has any. Mute is locked. Can you?
Now it is. It's working. I just
Okay.
more of a comment. I wanted to thank the Beechwood team. You represented our program very well. There's challenges that we could not talk about related to insurance and decreased funding for our residential services. But as a team, the four of you and the rest of our team have put together a really solid program that's comprehensive in its nature and really serves our participants well. So this is a thank you to the four of you and to the rest of the clinical team that might still be listening. And we want to make sure that we share that with our clinical, with our structured day, our residential, and our nursing and medical team. So thank you.
I echo what Joel just mentioned. It's you guys are all, that interdisciplinary approach speaks for itself. And of course, there is that medical nursing and the psychiatry.
Absolutely.
And you guys collaborate with them so well. That makes it the whole person care.
Right. So thank you all.
Thanks, Joe. Appreciate it a lot.
Thank you.
Thank you.
Thank you.
Okay, thank you. That ends our presentation. Thank you all for joining.
Thanks for having us.
Thank you very much, Dr.
Yeah.
Thank
Mitsunari.
you.
Oh,
Thank
you're
you.
welcome. Thank you, guys.